Okay, so the topic for today is Tracoma. The learning objectives of Tracoma are the definition of Tracoma, the risk factors for trachoma, the WHO classification, a grading system of trachoma, and the control and preventive measures of trachoma. So basically, what is trachoma? Trachoma is a chronic infectious disease of conjunctiva and cornea caused by Chlamydia trachomatis. So this is a bacterial infection, and it is a leading cause of preventable blindness worldwide. So this is the most common cause of preventable blindness worldwide. The pathogen is as I said earlier, it is Chlamydia trachomatis. It is a bacteria and it is a gram-negative bacteria. Okay, so the trachoma inflammation may undergo spontaneous resolution or may not progress to conjunctival scarring, which can cause inward deviation of eyelashes, which is called as trichiasis, or of the lid margin, in which the lid margin is distorted. It is called as entropion. So the subsequent complication is the abrasion of cornea by eyelashes, which frequently result in corneal ulceration, which is followed by scarring and visual loss. And the presence of trachomatis inflammation is also called as active trachoma. Okay, so the pathogen is trachoma, and it has further subtypes which are chlamydia trachomatis type A, type B, and type C. So, talking about the pathogenesis, it is an epithelial infection with subepithelial inflammatory changes. The pathogen enters the epithelial cells of conjunctiva and cornea as inclusion bodies, and it is followed by lymphocytic infiltration of subepithelial fibrous layer with formation of follicles. Follicles rupture and are replaced by scarring, which cause distortion of conjunctiva and eyelids, resulting into complications. So there are stages of trachoma, which we are going to study. There are four total stages. The first stage is subclinical stage, in which the pathogen has entered and the symptoms are minimal. There is conjunctival reaction to the pathogen, and there is discharge. And immature follicles are present in the upper tarsal conjunctiva. The second stage is the typical trachomatis stage. It is the active symptomatic stage with watering, photophobia, and foreign body sensation. And there are enlargement of follicles, in which follicular hyperplasia is seen, which appears on tarsal conjunctiva. And it is not, in this stage, it is not present on bulbar conjunctiva. And the size of these follicles is 0.5 to 5 millimeter in diameter. Okay, so talking about the stages, follicular hyperplasia initially in palpebral conjunctiva is reported, and then bulbar conjunctiva is reported. And also there is hypertrophied papilla, which is vascularized sort of growth. It is differentiated by follicles, where follicles are pale and papilla are reddish in color. And then there is corneal pannus, uh, which is uh, uh, formed in subepithelial corneal vascularization along with lymphoid infiltration. Normally, cornea is avascular, and there is no conjunctiva present on cornea. So, in this stage, second stage, corneal pannus is seen. Corneal pannus is subepithelial vessel formation along with lymphoid infiltration, which is a normal immune reaction. Then corneal ulceration is common at advancing stage of pannus. Then papilla, what as I told you earlier, papilla are reddish elevated conjunctival epithelium, whereas follicles are subepithelial conjunctival lymphocyte collection, and the follicles are paler compared to papilla. Then this progresses to third stage, which is stage of scarring. In this stage, non-functioning fibers and normal conjunctival stroma is destroyed. This is an active stage characterized by beginning of conjunctival scarring. And in this stage, there is a characteristic typical feature of trachoma, which is Alt's line in Herbert spreads. The Alt's line is the linear line of scarring on tarsal all palpebral conjunctiva, which may occur 2 millimeters from the margin of upper eyelid. And then there are Herbert pits, which are shallow pigmented depression at limbus caused by necrosis and cicatrization of limbal follicles. Cicatrization is basically scarring. So Harbert pits are basically the which are formed after degeneration of follicles and after necrosis, and they are formed at the limbus. Limbus is the corneoscleral junction. Then there is stage 4, which is an inactive stage and stage due to complications of cicatrization. And in this stage, the scar contracts, which affects normal vision, and cornea is opaque, and there is reduction in vision. Then there is a WHO grading. World Health Organization has also graded trachoma, and there are 5 stages of trachoma. So it can be memorized by this mnemonic, which is FISTO. So the first stage is trachomatic follicles, which are 5 or more 0.5 millimeter follicles in upper tarsal or palpebral conjunctiva. The second stage is trachomatous inflammation, which is inflammation which diffusely involves the tarsal conjunctiva, which obscures 50% or more of normal deep tarsal vessel. Then the third stage is tarsal trachomatous conjunctival scarring, which is shortening of fibers. The fourth stage is trachomatous trichiasis. Trichiasis is when the eyelashes touch the globe, which is due to shortening of tissue after scarring. The eyelashes touches cornea due to distortion in normal eyelids. And then there is corneal opacity, in which there is reduction in vision. So this is the picture in which you can see Harbert pits, the corneoscleral junction. At limbus, you can see there are pits formation after necrosis of follicles. This is the sequelae and complications of trachoma, in which you can see Harbert pits. And in the second picture, you can see there is Art's line. And in the third picture, you can see the corneal opacity with spheroidal degeneration. This is the trachomatis inflammation stage. Again, these are papilla. You can see reddish. Again, this is a picture of trachomatis inflammation. This is the trachomatis scarring, as you can see in the palpebra. This is the arch line, which is formed in palpebral conjunctiva. This is trachomatis trichiasis, in which the eyelashes touches the globe, which causes irritation of cornea. Again, this is trachomatis trichiasis, in which eyelashes turn inward and touch the globe. Okay, so what are the impacts of trachoma? From the public health point of view, trachoma is classified as blinding and non-blinding. A community with blinding trachoma can be recognized by presence of person with lesions such as entropion, trichiasis, and corneal ulcers, which require urgent control measures. Entropion, as I told you earlier, it is the distortion of normal eyelid, which results in trichiasis. The non-blinding measures of trachoma often become blinding when other ocular pathogens interact synergistically, and enhance the risk of damage to eyesight. Individuals and families. There is loss of productivity and economic losses due to loss in vision. Then trachoma is a major preventable cause of blindness in developing countries, according to recent statement. About 1.9 million people currently suffer from visual impairment due to trachoma. Out of these, 1.9 million are irreversibly blind. 21 million are at risk of infection. Incidence has shown significant decrease during past few decades. The decrease has been mainly due to improved sanitation, water and housing, and implementation of control measures. It still remains a public health concern in developing countries. So how is trachoma diagnosed? It can be diagnosed through a number of measures. The first being Giemsa staining, which checks cellular response in epithelial cells. Then there is direct fluorescent antibody, which detects antibodies in smear. Then there is ELISA, which detects antibodies in blood. Then there is polymerase chain reaction test, which checks antigen. And then there is McCoy cell culture, which isolates the organism. For eye, the purpose of diagnosis in field case must have at least two of the following criteria: follicles on the upper tarsal conjunctiva and limbal follicles or their sequel Harbert pits, which I told you form at the corneoscleral junction limbar, and typical conjunctival scarring trachiasis, introversion of eyelashes, entropion, in which eyelid is rolled inward against eyeball caused by scarring of conjunctiva. Okay, so what are the factors? The factors is first of the factor is the age. In endemic areas, children may show signs of disease at the age of only few months. But typically, children from age of 2 to 5 years are most infected, contributing to high rate of blindness. Then it is more prevalent among females, if we see gender-wise, because the women remain more in contact with their children who infect them. Then environmental factors. Seasonal epidemics are associated with increased risk of eye-seeking flies. It is as trachoma is associated with poor quality of life. The disease thrives in condition of poverty, crowding, personal poor hygiene, poor sanitation. And the custom of applying kajal or surma is a risk factor because this is a fovite which our infected person can use, and an infected person can use that, and the disease will be transmitted. Then, in derived either direct sunlight, dust, and smoke irritants may predispose to infection. So this is transmitted by direct or indirect contact, the mode of transmission. With ocular discharges of infected person, infected fingers, towels, kajal, surma, eye seeking flies also play a role, sexually transmitted also. This disease is highly contagious. It tends to infect whole families, and it is carried by fomites, which are objects likely to carry infection. Then it is also sexually transmitted. Reservoir. Children with active disease, chronically infected older children and adults, they are reservoirs. Okay, so how can trachoma be controlled? First of all, the disease needs to be assessed. Then the primary objective is prevention of blindness. There should be focus on communities with prevalence of blinding trachoma indicated by presence of corneal blindness, trachomatis trachearis, and entropion. An epidemiological survey should be undertaken to identify communities with blinding trachoma. Then the magnitude of problem should be assessed, local condition, and other causes of blindness. Then there is a safe strategy by WHO. It is an acronym for surgery, antibiotics, facial cleanliness, and environmental changes. Surgery corrects eyelid deformities. Antibiotics are used for preventing the progress of disease. Then facial cleanliness reduces infectious secretion and reduces flies. Hand washing. And then there is environmental changes, sanitation and controlling flies in clean water. Then antibiotics. Talking about antibiotics, the objective of these interventions is to reduce severity, lower the incidence, and in long run decrease prevalence of trachoma. The antibiotic recommended is azithromycin or alternative, alternatively oily suspension of tetracycline. Treatment may be given to entire community known as mass or blanket treatment. In some programs, selective treatment is given in which whole population is screened and those with active trachoma is treated. In more than 5% prevalence, mass treatment is recommended. So, mass treatment, prevalence of more than 5% severe and moderate trachoma in children under 10 years is indication of mass treatment. Treatment consists of application of twice daily of tetracycline 1% ointment to all children or 5 consecutive days each month. One of the main difficulties is need for repeated application over a long period of time. Emphasis is placed on active participation of community in trachoma control activities and utilization of healthcare workers, primary healthcare workers, which makes possibility of wider coverage and greater efficiency. Then there is selective treatment. This is recommended for communities with low to medium prevalence. The treatment should be applied to individuals by case finding rather than by community-wide coverage. The principles of treatment remain the same. For selective treatment to be effective, whole population at risk must be screened for case finding. Then there is surgical correction. In addition to surgical antibiotic treatment, it is recommended for individuals with lid deformity. Then it should be actively sought out so that necessary surgical procedures are performed to prevent blindness. Then surveillance. Once control of trachoma has been achieved, provision must be made to maintain surveillance, which may be necessary for several years after active inflammatory trachoma has been controlled. Whole family group should be under surveillance. Health education. In the long run, antibiotic treatment should be carried out by affected population itself. The population needs to be educated. And the mother of young children, because they remain in contact most of the time, they should be target of health education as to how prevent the trachoma and what are the necessary measures for disease progression if one has the disease. Then primary prevention through health education for total elimination of transmission and permanent change in behavioral patterns such as hand washing and other hygienic measures. And then improvement of living condition and quality of life, like access to water, clean water. Then evaluation. In evaluation, trachoma control program must be evaluated at frequent levels. Effect of intervention can be judged by changes in age-specific rates of active trachoma and in prevention of trichiasis and entropion. The General Assembly, 28th General Assembly, in a resolution requested World Health Organization to encourage member countries to develop programs of prevention of blindness, especially aimed at prevention of trachoma, xerophthalmia, and other causes. Many countries now have trachoma control programs into national programs for prevention of blindness. Thank you. That's it.